Okay. I just came out of another Zoom meeting from the SSMH BPSD guidelines, and the survey came true that BPSD would be the term to continue to work with, since we are aware of that term and used to work with it. So I've been involved in treating BPSD for at least 20 years now, and so I'm very happy to share that with you today. I've received some fees from Jensen for CMA conference, and also some salary from the Quebec Ministry of Health. I'm managing the BPSD committee at the ministry, and also, as I said, on the CCSMH guidelines panel. So this is the disclosure for the program. Again, mitigating potential bias. So today, we're gonna talk about some objective. I'm just trying to put that aside. So first, distinguish categories of BPSD, their characteristics and their impact on patients and their relatives. Try to describe the general clinical evaluation process for BPSD and choose the most appropriate intervention to treat BPSD. So in 20 minutes, I should go on all those topics. The first slide is, as we said, try to distinguish or have common term when we are talking about BPSD, because it's very important to distinguish whether the patient or the resident is having some affective, I would call, symptoms instead of psychotic symptoms, or what we call frontal dysfunction symptoms, because there's more and more literature saying that all those specific kind of cluster of symptoms, they have pathophysiological differences, and also we treat them differently depending on what we know about them. So try to be more specific than just saying BPSD or agitation, because an agitated patient could mean an anxious patient, could mean a depressed patient, could mean someone who wanders around, could mean someone who's very aggressive. So it's important to be as specific as one can in order to discuss those symptoms. Frontal dysfunction are symptoms that arise often more tardively in Alzheimer's disease, but we can see them earlier in frontotemporal dementia, for example. So they are associated with a release from the frontal filter on impulsive impulses, basic impulses, or repetitive behaviors. So when patients are losing that kind of frontal inhibition, they could have stereotype or repetitive behaviors like wandering or vocalizations or movements, and they could have some primitive reflex like the grasp reflex or imitation or utilization behavior. So BPSD will affect almost all patients with dementia at some point in their disease, and it may be one or the other symptoms. It is associated with faster cognitive and functional decline, with earlier institutionalization, with increased mortality, with decreased quality of life, and also increased caregiver burden. Often it's the symptoms that would be the more bothersome to caregiver, more than cognitive or functional dysfunction, functional impact. They are also associated with increased use of physical and chemical restraints and increased cost for the health system. So when one is trying to evaluate or to think about how to implement an intervention plan for BPSD, one acronym that could be helpful is the DICE approach, which has been published by Kales in 2000. I don't see my slide. 2000 something. You see it here. So DICE goes for first describe, as we said, in most specific term as one could do, describe who's the patient, what is his behavior, what is the environment where it happens, what is the situation, and what would be then the target for treatment. I goes for investigate what could be the possible causes for the behavior. Is it a medical condition? Is it the side effects of medication? Is it because of the approach of caregivers, which are increasing the stress? Is it because of environmental issues, too much stimuli, for example? Then one would create an intervention plan. It could be either pharmacological, non-pharmacological, or changing the environment. And it would be important afterward to evaluate the effectiveness and also the side effects of this plan. I'm sure most of you are aware of PIECES. PIECES is a framework to try to assess factors that can contribute to responsive behaviors. So again, another acronym. So it goes on all the possible causes I've been talking just in the previous slides. So like physical causes. Is it because the patient or the resident lacks some the caregiver does not answer the basic needs like hunger or thirst or need to go to the toilet? Is it because of recent change in medical conditions, delirium, for example, side effects of medication, altered senses? Sometimes in long-term care, people are losing their glasses or their hearing aids. Well, they can be agitated because they lose another sense that could give them cues to approach the environment they are living in. Is it because of cognitive dysfunction, memory loss, or orientation loss, or the lack of the ability to move or to sequence tasks? Is it because of emotional symptoms, depressed, anxiety, losses, stressors, capabilities, the change in usual abilities or strengths? Is it because of the environment or because of social issues? So it may be interesting to go through all those causes and try to identify one, or often it's many of them that could contribute, and to try to build an intervention plan in correspondence with the causes that has been identified. So 3 types of intervention, as we said: pharmacological, environmental, and non-pharmacological. I need to emphasize that all, major guidelines are putting some emphasis on the need to rule out underlying medical problems and use psychosocial interventions prior to use medication. So that should be a reflex, not to go to prescribe lightly, but before trying to have some non-pharmacological interventions. Why? Well, because there are many symptoms that are not likely to respond to medication, or where medication is not a first line treatment. And you would identify here the symptoms that I've just described as being associated with the frontal dysfunction. So wandering, vocally disruptive behaviors, hiding, hoarding, repetitive activities, inappropriate voiding or dressing, undressing, eating inedible objects, resistiveness to care, are all symptoms that are not likely to respond to medication. And when someone is prescribing some medication, usually it's an antipsychotic or a benzodiazepine for that kind of behavior, one should keep in mind that they are just prescribing a chemical restraint. So it's not a treatment per se, it would just sedate and restrain the patient. What are the symptoms that could respond to medication? You see them listed here. So anxiety, depressive symptoms, but then we would more often prescribe an antidepressant medication. Antipsychotics are not first-line treatment for anxiety or depression. Sleep disturbance may respond to medication. Manic-like symptoms, severe psychotic or aggressiveness, and also sometimes sexually inappropriate behaviors could respond to medication. So what are the non-pharmacological interventions that could be used? The first chapter would go about staff education and caregivers psychoeducation, which has been described as being very efficacious for many BPSDs. Then there are some training about basic approaches. Basic approaches are more like the way we communicate to dementia patients. So I think in the English-speaking part of Canada, many professionals are trained with the GPA, the gentle persuasive approach, which could be an example of basic approaches. Then you have basic strategies like validation, validate what the person feels, or doing some diversion, trying to talk about something that would interest the patient while doing the care, for example, are very useful strategies. And then one would go on more, well, let's say fancy interventions, like modifying the environment or putting through non-pharmacological structured intervention. For education and staff training, you have those websites here. Well, the pieces you have here, and also Baker's provide some very interesting training educational resources. Caregiver psychoeducation, there are some also from Baker's and some in Quebec and French also. When thinking about some environmental intervention, one needs to consider first the visual and auditive stimulation level, trying to hide unhelpful stimuli, giving some temporal-spatial orientation cues, and try to personalize the space just as it is home-like. So for example, there are many long-term care, I don't know in the rest of Canada, but in Quebec, which are still very institutionalized, like, as you can see. So big corridor with a dead end are very bad for wandering patient. Instead of trying to build more home-like places for living which are more familiar to patients, that could just decrease BPSD in some of them. You know, here for wandering patients or some who wants to leave, the contrast here between the elevator door and the walls are very appealing, so it increased the risk of getting out. And here you see a fresque, a pictorial decor that has been put there, so it disguises the elevator door and decrease the risk for wandering and fugue for this patient. Having an exterior path to wander could also be a way to decrease some agitation for patients. It's very difficult to stay inside in our winter countries all year long. So having an access to an outdoor where they could go around is very helpful also. So these are just some examples of interventions to modify the environment that could be worthwhile thinking about. About more fancy non-pharmacological interventions, I need to put some emphasis on basic thing to consider, like they need to be individualized to the life story and the interest of the subject. they need to be utilized strategically to prevent BPSD at problematic time of the day. So if you know that at some, well, let's say for sundowning is the time where the patient would get agitated, then maybe installing him or her with a specific activity that is in line with their interest before that time of the day where it's difficult, it could be more useful to organize it that way. And they should be based on residual capacities, which are in Alzheimer's disease, more long-term memory, some procedural memory, and sensorial memory. That's why music therapy is often very useful, because those are memories, procedural and sensorial, which are preserved for longer term in Alzheimer's disease patients. So you have many kind of non-pharmacological interventions for BPSD. They can either be in order to enhance sensory capacities, or give some relaxation, some social contact, which can be real or simulated, some behavioral therapy, some structured activities, the modification of the environment as we've talked about, and the training also for staff members. Let's talk now about pharmacological interventions. What are the indications for medication? Well, it needs to be prescribed for behavior that are of moderate or severe intensity. They need to pose a health or safety risk for the patient or others. And so the benefits of the pharmacological treatment needs to outweigh the risk for those medications. So the general principles in geriatric patients is to start with low doses, go slow, but sometimes one need to go. So it means that, let's say for antidepressant medication, sometimes we need to go to higher doses that we could prescribe in adult patients. But if there is still some response and it's well tolerated, one needs to go. One should use one pharmacological agent at a time and check often for side effects, and know that a complete response can take 2 to 6 weeks. And one need to consider changing agents if there is no evidence of efficacy. And guidelines are saying that one should attempt to withdraw them progressively after the patient has been stable for 3 to 6 months. With this, this is mostly for antipsychotic medication. So these are the classes of medication that could be prescribed or are prescribed for BPSD. We'll go through them one by one. But first, just one word about treatment of pain, which is often undiagnosed and untreated, or my English is, I'm liking this word, is not treated adequately, let's say, in demented patients. So why is that? Well, we know that pain is common, and there's some article, I have the reference if you're interested in that, they just built an algorithm with stepped treatment of pain, and at the first level was just acetaminophen regularly for all patients, and they examined the level of agitation of patient, and just with the acetaminophen regularly decrease the agitation of patients. So it's talking about the underdiagnosed and undertreatment of pain in those patients. So one needs to think also about topical therapies and treatment for neuropathic pain. One BPSD that is that we need to think more about pain is resistiveness of care. You know, sometimes it's helpful to give some pain management medication, let's say an hour before giving the bath or things like that. SSRIs, which are a class of medication, well, antidepressant medication, they are first-line treatment for symptoms like irritability, lability, anxiety, depressed mood. And there are some literature that compared SSRIs with antipsychotic medication in BPSD patients, and they were effective to the same level of antipsychotic medication in mild psychosis. So if a patient is having some mild psychotic symptoms with some anxiety associated with it, it could be a good first-line treatment and may avoid the need for antipsychotic medication. They are taking 4 to 6 weeks for a full clinical response, and sometimes even more than that. But one needs to be careful about the QTC augmentation with citalopram and escitalopram, with antidiuretic hormone inappropriate secretion, and GI bleeding in patients that have a predisposition for that. Antipsychotics medications are indicated only if there is severe agitation and aggressiveness or severe psychotic symptoms. The literature is saying that they have modest effect compared to placebo. It's about a third reduction of symptoms. And the ones that are studied are olanzapine, risperidone, and aripiprazole. You see that these are very low doses compared to those that we give to schizophrenic patients, for example. They have an increased efficacy when symptoms are severe, which is good since it's the indication for which they should be prescribed. Quetiapine is still the most used, but there's no efficacy proven for those symptoms. In fact, I think it's efficacious only because it's sedating the patient at some point, but in a very paranoid or aggressive patient, it won't be that efficacious. And typical antipsychotics have less favorable side effects profile. They should be used only in emergency cases where haloperidol is still the only one, or about the only one, that has a rapid peak of action when given in intramuscular or subcutaneous way. So why is there some restrictions in indication for antipsychotics? Well, because they are associated with many side effects. You all know about extrapyramidal symptoms like Parkinsonism, but also akathisia. So akathisia sometimes can be mistaken for agitation. I have many patients who has been receiving some haloperidol in PRN, many PRN over a day, and they are more and more agitated when sometimes it's because of akathisia. So just by stopping the haloperidol, it may decrease. Tardive dyskinesias is affecting mostly elderly patients, elderly women. We talk about 25% of incidence after 1 year of treatment. So it could be very damaging to patients when it is associated with dysphagia or dyspnea, for example. And also antipsychotics are associated with many other side effects depending of the molecule and the dose and the strength. So cognitive disorders, falls, drowsiness, hypotension, anticholinergic symptoms, infections, edema, metabolic syndrome, weight gain, etc. And one should know that they are contraindicated in Parkinson's disease and Lewy body disease. I will talk just a bit about that a bit further on. They are for many years now a subject of a black box warning, FDA warning, and also Health Canada warning, saying that they increase mortality in patients with dementia with an odds ratio of about 1.54. And the prolonged treatment is associated with an increase in mortality risk also. They are associated with the cerebrovascular event, with strokes, an absolute risk of about 1%. So that's why patients taking antipsychotics should be followed closely, and the indication should be reassessed regularly because they are associated with major risk. Benzodiazepines are not a first-line treatment of any BPSD. They just have non-specific sedative and anxiolytic effects, and they are associated also with the risk of falls, of drowsiness, altered consciousness, even delirium, worsening of cognitive disorder. They could have an addiction risk if they are given regularly and with a weaning phenomenon. And some patients could also show some paradoxical disinhibition. But when one should prescribe a benzodiazepine, it should be short-term, and one should use the ones that are metabolically favorable to the elderly, which would be lorazepam or exazepam, for example. Cholinesterase inhibitors and memantine, well, they have an effect in maybe preventing BPSD or treating slight irritability, agitation at some point, but they are not very effective for severe BPSD, severe agitation and aggressivity. Cholinesterase inhibitors are, I must say, the first-line treatment for symptoms in dementia with Lewy body. Sometimes it can also improve psychotic symptoms. But when a patient is having some frontal symptoms of Alzheimer, for example, or frontotemporal dementia, it can increase those kinds of symptoms. So they are relatively contraindicated in this kind of presentation. There is occasional worsening of BPSD when we stop them maybe too acutely. So one needs to be cautious about that. And with memantine, there are cases of worsening agitation and hallucinations also reported. For specific problems, if we talk about frontotemporal dementias, SSRIs or trazodone, which both works on serotonin level in the frontal lobe, which gives a bit more inhibition, are the medication of choice. As I just said, memantine and acetylcholinesterase inhibitor can worsen the behaviors. And sometimes, unfortunately, we are obligated to treat with atypical antipsychotics because of major aggressiveness. Lewy body dementia or Parkinson's disease dementia, the first line of thought should be to try to lower dose or wean off other dopaminergic medication that could increase BPSD or confusion. The first one are anticholinergic agents, then COMT inhibitor, dopamine agonist, to stay only with the SNMet, the L-DOPA, and try to minimize the dose to a difficult equilibrium between mobility and psychiatric symptoms. First-line treatment would be a cholinesterase inhibitor. And as I've said, typical and atypical antipsychotics are contraindicated. That should be the first reflex of a clinician when seeing a Lewy body dementia or Parkinson's disease dementia patient, because in this very fragile population, they are associated with hypersensitivity for side effects, delirium, severe extrapyramidal effects, even to some point, some may develop malignant neuroleptic syndrome. The exceptions are quetiapine, which has very little efficacy demonstrated in double-blind studies, but often used because of its favorable side effects. in these conditions, you see that it's very low dose, and unfortunately sedation and hypotension are often limiting. Clozapine would be the treatment of choice at low dose. It is described between 6.25 to 50 milligram per day. There are at least 5 double-blind studies which proves its efficacy in those patients. But unfortunately, even if it's a low dose, one needs to have some blood work regularly every week, because the agranulocytosis associated with that medication can happen even at very, very low dose. So it should bring us to the case discussion. I stay silent now and listen to you.
Thank you so much, Marie-Andrée. I think we have a few minutes for questions before we get on to our case. So I will, if that's okay, I'll open it up to the group and see if anyone has any questions or comments they'd like to make. An excellent presentation, remarkable how much you've covered in such a short period of time in a very complex area. So thank you for that. So can I ask if folks would like to just put up their hands if there are questions, or put questions or comments in the chat? Look forward to hearing from everybody. Shelley.
Hi there. I was just wondering if someone had a sodium level that was a bit below the reference range on the labs, would you start an SSRI, for example, and then recheck it? Or how could you sort of navigate that, I wonder? For someone maybe who has anxiety and you're looking to start something. I have someone in mind.
Well, usually that complication specific with SSRIs survene in the first month or so of treatment. So I wouldn't refrain myself from prescribing it if needed. They are first-line treatment for anxiety, but maybe I would propose to check on the sodium level, let's say at 2 weeks and at 4 weeks. And also I always tell patients and family to call me if there's anything, any side effects like confusions or something that doesn't look more than the maybe little GI distress that are usually associated with those medications. So I explain them the risk for that. Then with a low sodium, well, I would like to know what could be other etiologies. Is the patient under low blood pressure medication, or is it the only time I would refrain or be more cautious is with a clear history of a complication of low sodium because of an SSRI. Then there are some antidepressant medication which have less risk for that, but besides that, that would be my my plan.
Does that help, Shelley? Great, thank you. And Tracy, I don't know if you want to comment on your question in the chat, seeing a lot of typing for responsive behaviors and that they're getting drowsy. So yeah, it's fascinating that we're using the drug, which seems to be the least evidence is most prescribed.
Well, it was marketed as having less EPS side effects. So I think people thought it would be less risky to prescribe this one, but in a very frail or fragile patient, the hypotension and also the sedation could be also risky because of falls. So I'm not sure that it's always a good choice to go with that. And of course, in a very paranoid or aggressive patient, it wouldn't be efficacious at all. And we would lose weeks of treatment trying to increase the Seroquel without efficacy. So I would go to Risperidone directly for that kind of patient. Yeah.
I wonder if we reach for it as well, because it has such a wide dosage range. We can start with such a tiny little dose. We feel like we're not doing harm, and yet we're doing harm by delaying the use, as you say, of treatment that would be more helpful. So I think you're right. Anne has a practical question around clozapine and monitoring, with CBCs mentioning that she's seen it monthly in non-geriatric patients.
Well, monthly, it's after it's been monitored weekly for many months and it's been stable. Then the monitoring agency tells the clinician that it could be, prolonged to a monthly then, but usually it's not in the first, at the beginning of treatment that we can space out the monitoring.
And it's very directed, isn't it? It's sort of the agency kind of tells us how to repeat every week and then every 2 weeks. And then if you have an abnormal CBC, you kind of have to start back at the beginning again.
Yeah.
Thank you. Other comments or questions? I wonder if folks have any comments around reading my mind around assessment methods. So using the DOS, the Dementia Observation Scale, looking at things like ABC charting. I see SJV there, but I'm sorry, I don't know your full name, but I'll just call you SJ if that's okay.
Well, my apologies. I was wondering why they were asking for the attendance, and I guess it's because my name shows SJV and not Kristen. So yeah, I just wanted to know if there were any other effective assessment tools. We historically and habitually in long-term care use, as Sid was saying, the dementia observation system. Is there anything else that would come recommended to observe any types of changes or whatnot after a med change has been completed for a resident?
Well, you have specific symptoms tools like, the ENPI for all BPSD, or the Cohen-Mansfield agitation inventory for agitation, or the L-Gaze wandering scale for wandering. So those could be other tools, but I think clinically I prefer to have some observation, either the grid under 24 hours, 7 days, where we could put some color. Let's say if we try to monitor when the patient is sleeping, introduce a treatment, then in blue we see the hours where the patient sleep. It's very useful and very visual. Or the ABC, as you said, trying to describe all the context surrounding an event for, let's say, aggressiveness from a patient, and trying to see what intervention helped. Sometimes it's difficult to get the staff or caregivers to do it very precisely. So one needs to be realistic with the goal, saying that and explaining to staff members that, we need to do it at least for a week correctly in order to see if the treatment plan is working, and focus on only one behavior, the one we want to prioritize in our treatment plan. So then there are more chances that it will be completed efficaciously, so we can manage and reevaluate the intervention.
It's certainly a world of many, many acronyms, isn't it? I see in the chat that Marie-Lise has put the BSO DOS as one that's helpful. Behavior Supports Ontario. If you go to their website, it's a nice version of the DOS, where it also helps you guide staff to do a little bit of problem solving and get into some of the reasons behind, and the antecedent behavior consequences model, the idea of what came before, what was the actual behavior, and then what came afterwards, so that you can try and identify some patterns. Very helpful. And I will call you Kristen instead of JB from now on. Maybe a good time for us to go to our case, and then